In this presentation, I will talk about oral lichen planus. It's a case report. First, we're gonna talk about the case, general information about the case. A 55-year-old patient, black, male, was referred to oral diagnosis services complaining of rough tongue. So his chief complaint was rough tongue. He said that he has painful symptoms during ingestion of hot foods, and that these symptoms had been previously treated with topical medication like miconazole and statin. However, the lesion did not regress. The patient is medically fit. The subject reported habits of smoking and drinking alcohol. At clinical examination, the lesion was localized in the tongue, in the dorsum of the tongue, and was a papillar form, as you can see in the left picture. And in the right picture, there is a white striation in the right and the left buccal mucosa with no ulcer present. Upon histological test, the histological characteristic of this specimen revealed a fragment of oral mucosa lined by stratified squamous epithelium with ortho or parakeratosis and degeneration of the basement layer, showing a lymphocytic infiltrate in a band-like pattern. And this pattern, which lead us to the diagnosis of lichen planus. Now we're going to talk about lichen planus. Lichen planus is a chronic autoimmune disease with unknown etiology. So the etiology of the lichen planus, we don't know it, but we can. There's some literature that said that maybe because of drugs, anti-malaria drugs, or dental materials like amalgam composite or metals. Also maybe because of hepatitis C virus. And stress was identified as one of the most frequent causes of increasing the severity of the disease. So if there is stress, the severity of the disease it will increase. The main sites are the buccal mucosa, gingival, and tongue. Uh, and the most clinical presentation is a whitish hysteria. As you can see here in the picture, there is a lichen planus in the tongue. And as you can see in the figure A, there is a lichen planus in the lip, and in picture B, there is in the upper eyelid, and picture C in the inferior member. The differential diagnosis. Maybe it could be associated with medication, lymphoid reaction, or restorative material, or leukoplakia and lupus erythematosus. The oral manifestation of lichen planus have been described in the literature and can be classified into three types: reticular lesion, atrophic or erythematous lesion, and erosive lesion. The reticular type, as you can see here in the lip and the buccal mucosa, we see white lines. Atrophic or erythematous, here, as you can see in the buccal mucosa. And the worst type is the erosive type, and it's the most painful. The diagnosis of oral lichen planus is based on the clinical and histopathological findings. As we said in the histopathological, we saw a lymphocytic infiltrate in the subepithelial region in a band-like pattern and degeneration of the basal layer. Now we're going to talk about the management and the treatment. First, the choice of treatment depends on the severity and discomfort. Unfortunately, there is no treatment to permanently resolve the lesion. So there is no active treatment to resolve the lesion, but we can use drugs are used to improve the condition of the patient. The active components are corticosteroids such as triamcinolone, and also the medication that was talking in this case was dexamethasone, and clopidogrel and trimecanolone has been used in the patient with oral involvement. Of course, the lichen planus can uh, can affect the skin and oral mucosa. So if it affects the skin, we transfer it to the dermatologist. Also, maintenance of good oral hygiene can enhance healing and lessen the symptoms. Surgical management we could use it, including cryosurgery and carbon dioxide laser has been performed in oral lichen planus lesion, but surgical excision is not recommended as the first choice treatment due to the inflammatory conditions.